afternoon or good evening, everyone. I'm just going to wait a couple seconds as we let everybody join into the webinar here. I know we've got tons of people who joined us in the waiting room a little bit early, which is great to see. Right out at the end of the day, Eastern time here. And I hope you all are doing really well. Now that we're seeing tons of people come in, I will do my first piece of housekeeping or first little icebreaker, which is open up that chat button in your Zoom toolbar and just type in where you're tuning in from today. We often get people from across Canada, some people from the States, of course, and even internationally overseas too. So let us know where you're coming in from. Awesome. Well, my name's Troy. I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm excited to be with you today. We have a guest speaker with us, Dr. Paul J. Kim, who I'm really excited to introduce in just a moment. Before I get there, I just want to thank Ergo for making this webinar possible today. It's going to be a very interesting topic, and we're going to have tons of time for question and answers at the end too. So throughout the duration of this webinar, please make sure to type in your questions into that Q&A toolbar in your Zoom toolbar. That'll make sure that we can organize them and make sure we give you a chance to, or that we have a chance to respond to as many as possible. So today's webinar is going to be on evolving thought on solution selection for negative pressure wound therapy with Instillation. And we're going to be playing a recorded presentation here by Dr. Kim. Dr. Kim is on the line with us here, however, and will be available for question and answers at the end. So we do have a live question and answer. Don't worry about that. But we wanted to make sure we can get as much good content as possible from the recording. So Dr. Kim is the medical director of the wound program at the University of Texas Southwestern Medical Center in Dallas, Texas. He's also a professor in the departments of plastic surgery and orthopedic surgery at UT Southwestern. Dr. Kim received a Bachelor of Arts degree, magna cum laude, in psychology and biology from the University of Colorado at Boulder in 1995. He earned a Doctor of Podiatric Medicine degree at the Ohio College of Podiatric Medicine in 2002, receiving multiple honors. He then completed a surgical foot and ankle residency program in 2005 at Inova Fairfax Hospital in Falls Church, Virginia. And Dr. Kim also received a Master of Science degree in Clinical Research Management from Arizona State University in 2012. He's also a fellow of the American College of Foot and Ankle Surgeons. And Dr. Kim has received intramural and extramural research grants in wound care, diabetic limb salvage, and tendon pathology. He's also chaired multiple committees related to research and evidence-based medicine and the diabetic limb for national and international organizations. He's a national and international speaker and has authored over 150 basic science, clinical manuscripts, and book chapters on a myriad of different topics with specific interest in the diabetic limb. And today we're really excited to have him talking about our negative pressure wound therapy topic here with Instillation. So what I'm going to do is just remind everyone to definitely put your questions into the Q&A box as we get going. And oh, sorry, one more thing. Finally, we're enabling what's called Wordly, a AI tool that helps translate the transcription of today's webinar in both English and into a different language. So if you would prefer listening along or reading along in a different language like French, for example, you can actually just click on the Wordly, should be a little Wordly icon and drop-down menu in your top right corner of your Zoom screen. I've also in the chat posted a link. So if you click on that, it'll pull it up side by side with you, and you should be able to listen or read the transcript at the same time in another language. Thank you so much for doing that, everybody, and I'm going to now pull up our video.
Thanks everyone for joining us in this webinar, Evolving Thought on Solution Selection with Negative Pressure Wound Therapy with Instillation. This is a topic that I've been pretty passionate about for the last decade of my career, and the way that I think about this has changed. And I think with more experience by people using this device in conjunction with different kinds of solutions, I think there's been more information that's been gathered and our understanding has improved significantly. My name is Paul Kim. I'm a professor in the departments of plastic surgery and orthopedic surgery at the University of Texas Southwestern in Dallas, Texas. I'm also the medical director here. This is my disclosure slide. I have received research and consulting funding from Ergo Medical. I always talk about this as my first slide in every presentation that I give. I call it the wound equation. And whenever we're faced with a patient, whether it's in the clinic or as a consultation in the inpatient side, we think about their healing potential. Now, we may be thinking about it even subconsciously, but we are thinking about this. We want to know if a patient is capable of healing. In the numerator, there's a 1, the denominator, there's bacteria, perfusion, and tissue mechanics. We know those are the drivers or the major drivers of healing. However, the host also plays a big role in this as well. And the host is not very well defined. It's certainly their comorbidity profile, for example, if they have diabetes, peripheral vascular disease, obesity, and so on. But there are other factors, including their genomic profile, their access to diet and nutrition, their access to healthcare. All of those things are drivers of healing potential. In the kind of the larger scheme of things, we have to understand that we work within health systems. Whether you're in Canada, the US, or in Europe, or in South America, or in Asian countries, we know there are certain drivers of what we do. And we sometimes don't have control over that. We want to find things that hit certain criteria so that we can continue to use them. We used to live in a world where things were more costly and less effective, and that was okay. And some of us lived in a world where things were less costly and less effective, which is not ideal. I think in the United States, we live in this world, or we lived in this world where things were more costly and more effective, which is not the right place either. We need to be somewhere in between where things are less costly, more effective, providing more efficient care in the delivery of health in any country that we live in. When we talk about that in terms of negative pressure wound therapy with Instillation, we know that it's part of a larger package of negative pressure wound therapy devices. What we're going to focus on today is Instillation therapy, but there are other types of negative pressure, including portable designs, incisional, and open abdomen. All negative pressure is based on the same foundation, but in the walls of that house is Instillation therapy, and the roof is a novel foam that's used, and also the shingles, which is a novel drape that's used. And this concept is marrying two different kinds of technologies, which one is negative pressure wound therapy, and the second is solution irrigation. So if you think about this, and if you've never used this or never seen this, essentially what happens is solution dwells on the surface of the wound, then that solution is evacuated, then negative pressure wound therapy is then applied, and this is in a pre-programmed manner. So you can see that the pivotal piece is the solution, and certainly negative pressure wound therapy by itself has benefit, but I think if you add Instillation or solution to it, I think it can have even more benefit. And we're going to talk about some of that data in a little bit. We have to understand that negative pressure wound therapy is a very old technology. It goes back to 1994. And there has been a prior kind or type of Instillation therapy that was not very well adopted in the late 2000s. With the newer generation of negative pressure wound therapy with Instillation, which was introduced in 2013, and then the novel foam in 2017, and an automated volume estimator in 2022, the use of this device and this technology has really expanded. It's become a lot easier and more reliable. If you look at the data, there is a lot of data that supports the use of negative pressure wound therapy with Instillation. And you start from animal to bench studies to all the way to a meta-analysis. So we know that it works, and we know it actually works better than standard negative pressure. So the question remains, do you need to use antimicrobial cleansers with negative pressure wound therapy with Instillation? There are many antimicrobial cleansers and surfactants out in the market, including Vashe, which is hypochlorous acid. Other people use acetic acid, dilute bleach, betadine, goes on and on. And it sometimes largely depends on the availability in your facility. But it's really important to remember there's a balance. We need to think about things like its efficacy or effectiveness of that solution, their spectrum of activity, their tolerability, availability, and cost. Ultimately, it goes down to safety, right? If it's a safe solution to be used, and does it actually work? I'll tell you, my evolving experience started when I was working at Georgetown University Hospital. This is over now almost 6 years ago. When we first started to develop our understanding of negative pressure wound therapy with Instillation, we looked at various types of solutions. And what was interesting to us, and I'm going to show you that data later, was it didn't seem to really matter what kind of solution you used. At the time, I didn't really understand that because, microbial solutions have been demonstrated over and over again to be efficacious against bacteria, fungus, and yeast. So it didn't make sense that you wouldn't get any necessarily better results using these solutions. What I've come to understand as I travel the country and the world, and working here as the medical director at UT Southwestern, is that not every facility was like ours at Georgetown. In fact, Georgetown is kind of an outlier. It was very surgically heavy, meaning we did some deep excisional debridements in the OR, and we know in the wound care world, in most places, the surgical management of wounds is just simply not done, or it's not done very frequently. So when I came to UT Southwestern, I realized that there was a lot of Vashe being used in our health system. And I realized that, one, it was because of the fact that there wasn't a real surgical focus to wound care here. So here's an example. This is our wound clinic storage closet. And you can see that we have a lot of Vashe stocked within our wound clinic, and we use a lot of this. We know that Vashe is, the pH is physiologic. It's very well tolerated. It's broad spectrum, and there is some debridement component to this, and it's relatively inexpensive compared to other antiseptic solutions. You don't have to have the pharmacy mix it, so there are certain advantages of this. Here is on the inpatient side, in the acute side, in our ORs, we also use pure hypochlorous acid preserved cleanser, and you can see this is our negative pressure wound therapy tower here between the ORs. And on the floors, we also have lots of Vashe being used. Essentially, on the floors for wounds, we saturate the gauze and apply to 5 to 10 minutes, and debride, apply wound ointment, whatever you want to do. In the outer, and then in the OR space, we use it in combination with instillation therapy when patients are either being bridged to closure or their wound needs to be converted to a healthier state. I'm going to show you some examples of that as well. This idea of using negative pressure wound therapy with instillation was really born out of this observation by many people that use negative pressure, that there was a smell to the wound base after removing the foam. Also, there may have been some slime in the area. Yes, it did improve granulation tissue growth. However, I think there were some more incidents of infections. In fact, this study, looking at bacterial load using negative pressure wound therapy, you can see that after applying traditional negative pressure wound therapy, there was a significant growth in almost all bacterial species. This was one of the first studies that was published looking at, in an ex vivo model, looking at use of instillation therapy with the various different types of solutions. And you can see this is data from Greg Schultz's lab that showed that using any instillation or antimicrobial solution was more effective than not using it. So that got us our interest when I started to look at this over 10 years ago. And one of the things that I looked at in this paper was the use of something called PHMB, which is polyhexanide with betaine. And I said, well, look, it does a really good job of eradicating essentially or reducing the amount of bacteria in a biofilm model in this paper. So we looked at that and we said, maybe that is the right kind of solution to use. So we published a series of papers using instillation therapy with PHMB at the time, and that's the paper on the left. But remember, again, this was in a setting where we did wide, aggressive excisional debridement prior to applying instillation therapy. We followed that paper up with one using just standard negative pressure, standard normal saline. So we compared normal saline versus an antiseptic, PHMB in this case, and showed really no difference in outcome. So again, it made me scratch my head going, well, that doesn't make sense really, right? Because normal saline has no antimicrobial components to it at all. However, I kind of neglected to think about in the wider scope of things that we were doing a pretty aggressive debridement. Therefore, it probably didn't need anything in addition to that. So normal saline was okay. And as I also mentioned earlier, there's different algorithms of care for infected or contaminated wound. In some cases, if the patient's admitted for that problem or as a secondary problem, the patient's taken to the OR, perhaps for excisional debridement, a wide excisional debridement, and installation therapy is applied, and then the patient can be discharged on standard negative pressure wound therapy or installation therapy in some facilities. Another algorithm of care is, again, going to the OR after installation therapy is applied. So in preparation for that first OR visit, and then you go to the OR once to close or cover the wound. However, in most cases, what I've found, at least in the places that I've visited, again, most people that take care of wounds are non-surgeons. They'll apply installation therapy perhaps right away, and with no surgical debridement performed, perhaps a little bit of bedside debridement, but not in all cases. So I think in this environment, I think use of an antimicrobial agent is very important. So here's a couple of case examples. This is a patient that's very sick, one of my patients, type 2 diabetes, PVD, all the kind of the standard things. And the patient was too sick to go to the OR. So what do you do with tissue that looks like this? It looks very indurated. It just doesn't look very good. So this is 4 days with installation therapy with novel foam and the use of Vashe. And you can see that it's penetrated that non-viable kind of fibrotic looking tissue, and you have healthy granular tissue that's now exposed, and you've cleaned it very well. Here's another case. This is a patient, again, too sick for surgery, was a transfer to our hospital, had a prior debridement performed. That incision opened up on the plantar heel. And again, the patient was too sick for the OR, so we just started and initiated installation therapy with Vashe. And you can see that on the bottom right pane, how good that tissue looks as compared to the one on top. Here's another patient, is a sacral ulcer in the ICU, no sharp debridement. Again, the patient was very ill. And you can see day 0, day 5, and day 21. Now, for these patients, we all know are very sick. So the hope for healing is not really a goal. What we're trying to do is eradicate the likelihood of infection and try to convert that wound to something a little bit healthier. You can see that on day 21. That's what's happened. Here's an ischial wound. You can see that necrotic tissue where that arrow is. No sharp debridement again, using installation therapy with Vashe. And you can see the difference there in the tissue quality at day 10. Now, I think there is also a different, beyond the antimicrobial components of pure hypochlorous acid, I think what also it can do is it can break down non-viable tissue. So in essence, it kind of debrides or cleanses that area and removes all of that tissue. I think that's an added benefit of using Vashe. Here's another case of a calciphylaxis of the medial thighs. And as you all know, calciphylaxis is very painful. So the patient declined surgery, declined any kind of debridement. So we use installation therapy with Vashe. And you can see the conversion to a much better state by day 8. This is another example of essentially the dual action that we're seeing. We know that installation therapy has a mechanical debridement component as well. But I also think that Vashe also assists in this mechanical debridement and assists in the mechanical removal of germs. And you can see that's on a trochanteric wound. This is a hip arthroplasty, that surgical incision that dehisced. You can see by day 7 how robust that tissue looks and how healthy that tissue looks as compared to day 0. So do you need to use it? Do you need to use antimicrobial agents with installation therapy? I think if you do a really good surgical aggressive excisional debridement, I don't think you necessarily do. So you could use normal saline in that case. But in those cases where, again, you don't have access to a surgeon, or that surgeon's simply not available or doesn't do a good job debriding, or if there's concern of resistant bacteria or heavy colonization, or there's a delay in the OR, or a patient's unwilling to have surgery, or the patient's simply too sick, then I think use of an antimicrobial agent like Vashe is very important, because I think you need something more than just normal saline in those cases. There's been a series of expert consensus guidelines that have been published over the years, and the first one that I joined was in 2013. And at that time, there was a lot of discussion on settings because it was a relatively novel therapy. And so there was a discussion on solution selection, and the use of Vashe was not included in that initial international consensus guidelines. As we continued to meet every couple of years, the thought continued to evolve. And what we found was in 2020, hypochlorous acid or pure hypochlorous acid was then came kind of, it drifted to the top of the list as far as one of the solutions to be considered when using instillation therapy. The most recent international expert consensus panel, we published this paper in 2023, and its aim was to address certain concerns or questions that people had using hypochlorous acid. Because there was some discussion among some clinicians that the solution itself would precipitate and crystallize and cause alarms with instillation therapy. What we know is that hypochlorous acid cannot crystallize. What I think is going on is that the combination of the mechanical energy of instillation therapy by itself and negative pressure, along with the use of hypochlorous acid, pure hypochlorous acid Vashe, I think increases the ability for non-viable tissue and bacteria to be removed. So I think you're seeing the result of that, not the crystallization that some people think has happened. Now, we also discussed in this international consensus panel that included the US, Canada, and other countries in the Europe, that it was not only safe, but it's recommended to use hypochlorous acid, pure hypochlorous acid, or Vashe in conjunction with instillation therapy, and at the earliest time point possible, because I think the longer that activity continues, the better your result will be. So in conclusion, in this consensus panel, we all agreed it was safe, effective, and perhaps more effective than any other solution that the experts had used. And early initiation and more rapid cycling is necessary. And for those that are having issues with alarms, we also recommended certain methods to get around that, including using 2 pads, an ingress and egress pad, and also perhaps cycling faster, because I think what happens is if it cycles slower, then it tends to, the debris of the wound debris tends to clog certain things up. So I think this is a very important pivotal paper, and if you are interested in reading more, please look for this. It was published in Wounds Research. Part of this story that we're telling, that I'm telling, it's not only about efficacy and safety, which we've been talking about all along, but also the cost to a healthcare system. And so we know the use of instillation therapy primarily with the use of antimicrobials, including Vashe, leads to shorter length of hospitalization, decreased number of OR visits, and decrease in 30-day readmission rates. So I think that in itself is very impactful, because I can't think of many wound care related products that can hit on all of those things. There was a great supplement that was published in 2021 with a variety of different specialists included that looked at different anatomical locations, different wound types, including trauma, pressure ulcers, acute wound, diabetic foot ulcers, that we discussed the use of instillation therapy in great detail. And I would recommend you all read this as well. So in conclusion, there is a benefit of using antimicrobials and negative pressure wound therapy with instillation. Clearly, there's a reduction in bacterial burden, removal of non-viable tissue, and wound conversion to a healing state. Now, some people in some healthcare systems, they just want to get the patient out of the hospital, and we need to get that wound to a point where it's clean and healthy. And I think the instillation therapy with the use of antimicrobials gets you there most efficiently and most cost effectively. Thank you very much.
Yeah. Alrighty, well, I'll come back on here too, and I'll invite both Dr. Kim to come back on. And In the background, we also have Dr. Debashis Chakravarty who's a vice president and a scientist here with Ergo Medical, who may help out as well, just in case there's some questions that go there too. But Dr. Kim, I'll first say thank you for some of all these great case studies, fantastic information as well, and it's an interesting topic in general. And we can tell that's the case by some of the questions that have been coming in. So if we can go right into it here, and I'll remind everybody in the background, if you do have any questions, please put them in the Q&A box. We'll get to as many as we can here. We should have a decent amount of time to go through them. But one of the things I wanted to first just ask is more of a clarification question here, maybe for Debashish. Someone was just asking about Vashe and debriding. They just wanted to make sure that it is actually indicated on the bottle there.
Yeah, I mean, I saw that question. Can you hear me okay?
Yep, we can hear you great.
And I answered it. How it exactly does that is a subject of research, and we continue to publish in this area. I think in the real fine print, I'm calling from the USA, and I think the labels are very similar to that in Canada. Is we say that coupled with mechanical action, Vash debride, something to that effect. And of course, when you're using negative pressure wound therapy, it is really making a machine do your work. And then, so that's how it works. But it's visible to the naked eye, as well as in the cases that Dr. Kim showed. So how it does it, it's research will continue in this area.
I'd like to make a comment on that
Mhm.
too, Troy, because it's
Yes.
been quite a long journey, and this is why the title of this talk is the evolution or the changing thought of using installation therapy. I've always viewed the installation therapy with negative pressure as it's like a washing machine. So you can get clothes cleaner with water, just water. But if you add detergent to that, then you get the clothes very clean. So I think there's a synergistic effect with using Vosh and using installation therapy. I think they just work better together and they fit nicely together. So I just want to make that point without going into the technical reasons why, like the physiological reasons, the interaction. I'm not exactly sure. There's probably some chemical interaction with the tissue to allow it to break up better using Vosh, but we have observed that there is a significant difference in the tissue quality, and certainly from the bacterial perspective, there's a decrease in bacterial burden to the wound using Vosh in combination with installation therapy.
Yeah,
Thank
as a
you.
company, I would say that I completely agree with what Dr. Kim said. As a company, though, we focus on the augmentation of the mechanical activity. It's a force multiplier. And then exactly how it does it is a subject of ongoing research. Dr. Kim, there's a question here. I want to jump in and ask you because you're the right person. Is it safe to do installation in wounds with undermining or tunneling? Now, when we are just doing the soaking with gauze, it is fine to use gauze on those types of wounds for soaking. But how do you answer that question with respect to installation?
Yeah, I think, first of all, I think if you have tunnels or a significant undermining, you have to be able to explore them because you just never know where they go. So if you have an abdominal wound, you want to make sure those tunnels or undermining doesn't go into the abdominal cavity because then the patient's in trouble. So I would be very hands-on, do a lot of palpation, stick your fingers in those holes and see where they lead. If there's a terminal end to it, I think it's perfectly safe to use installation therapy with Vosh. One of the things that you have to remember is even using standard negative pressure, many of those tunnels and undermining will actually collapse with the application of negative pressure. So that in itself will close those tunnels. But again, be always aware of where those tunnels are actually leading you to.
We have one more question here. By using installation therapy, what is the time frame for the wound to heal slash close? It's a very general question. I hope you can give a suitable reply to that question, Dr. Kim.
Yeah, so we use negative pressure with installation in the acute side here in the United States mostly. You can also use it in LTACs. But for me, when I view this technology or this device, it's a step towards healing or step towards wound bed preparation. I am not a big advocate of using negative pressure for months on end. I've seen that happen. I think the risk of infection starts to climb exponentially. So I try to convert that wound in the inpatient side by using instillation therapy with something like Vashe. And then once the wound bed is prepared, if the patient's still in the hospital, then I'll go back and I'll skin graft close or move muscle or soft tissue around. But there are cases where patients are sent home with traditional negative pressure once that the wound has kind of cleared its burden, and then the patient can be discharged on traditional negative pressure. Then I follow them very closely, and my team follows them very closely outpatient, and other teams, other surgical teams follow patients outpatient. And then as necessary, they'll stage for closure or coverage.
Dr. Kim, a related question. Is there a point where you switch to regular therapy, meaning, I guess, going from installation to Vash soaking with negative pressure wound therapy after a degree of healing?
Yeah, it's so healing is one outcome you want to look for, shrinkage in size and overall volume. However, we see a more rapid conversion of wounds using instillation therapy versus traditional negative pressure. Now, traditional negative pressure still works. I'm not saying it doesn't work, but I think that instillation therapy actually accelerates it even to a greater degree. And that conversion is a robust one. And those of that used instillation therapy in Canada has seen the results. It's different than traditional negative pressure. It's much better. And so, when do you switch? Well, again, like I said, if there is a clinical outcome where I want to close or cover, and the wound bed is ready, meaning it looks like a nice, healthy, granular bed, it's filled some depth, then I'll go ahead and close or cover. Now, in those other cases where the wound has been converted to a healthier state and the patient's being discharged, then you might want to switch to standard negative pressure. Or if the size of the wound has decreased to a point where it's really the installation's not doing much anymore, and it's so small, the volume of solution that you're using is so small, it's just simply not necessary, then I'll switch to something else like traditional negative pressure.
Thank you. There's a question I want to address. Are these okay to use for a person that has allergies slash sensitive skin? If not, what would be the best use? Now, I can tell you purely without the installation angle, the use of VASH is extremely safe because we absolutely, through a vigilance process take record of any allergy type complaints that come to us. They're very rare. And it's not surprising it's very rare because pretty much VASH has the ingredient noteworthy, that is hypochlorous acid, and we make it ourselves. It is there in the wound environment naturally, and so we don't expect allergies or sensitive skin to be flaring up with the exposure to VASH, and we don't see it. But with installation, do you see any problems on skin, Dr. Kim?
I really don't. It's a very because of its chemical nature, it's not irritating to the skin or the surrounding skin. Certainly, if you don't use good protection around the peri-wound area, any kind of fluid can cause maceration, so be aware of that. So you want to get a nice seal. You want to make sure that the wound has been isolated.
How do you double pad?
I think the double pad, I think what they're meaning about double pad is using the two lily pads. So so you have an option with instillation therapy. You have a single lily pad where you can ingress fluid and egress fluid out of the same line, if you will. The double system, you ingress with one and you egress with the other. So the idea is, this issue of perhaps precipitation, which, like I discussed, just doesn't happen. I think it's what's happening is there's been such aggressive removal of bacteria and just general bioburden. It's clogging because those two ports are so close to each other on the single lily pad. If you have two of them and they're spaced apart, I think you're going to have less of those problems.
I've heard gravity being used to its advantage. And I know Marian Obst speaks about that. Do you use gravity to your advantage,
Yeah,
Dr. Kim, for
absolutely.
installation?
And that's, Marianne is the world expert on use of instillation therapy. But I will tell you that you do want to use gravity because remember, you're using fluid that's dwelling on a surface of a wound. So gravity is going to pull it towards the ground. So you may not be getting fluid to all areas of the wound. So you may have to overestimate the amount of solution that you use. If gravity, if gravity is helping you, meaning it's on like the dorsum or the ventral aspect of the body, then the gravity will pull the fluid down towards the wound base.
So you may, in those cases, you may need to use less solution.
Fantastic. I have a question. Generally speaking, we don't address competitive products, but this one's an interesting one because it relates to the pH issue that Dr. Kim, I think, referred to in the talk. The right pH is very essential for wound healing. We know this. Why Vashe specifically and not another brand name is given, NSF, for example? What is the reason behind that? I think what it behooves you to do is to look at the label of the products. If it says hypochlorite, it is bleach-like compound, and its pH is likely to be very high. And high pH is typically cytotoxic. Make your own judgment in that regard. I would just say that if we don't have access to NPWT with installation, could we use Vashe to soak for 5 to 10 minutes or longer and use the regular NPWT and expect similar results? And this is in line with another question where somebody is in a site of care where installation is simply not available in community care. How do you answer that question, Dr. Kim?
So I look at the kind of the kill curve for bacteria. If you were going to use Vashe, and when I first got here in the wound clinic, what the staff was doing was just kind of rinsing the Vashe over the surface of the wound. I said, no, it needs contact time. So it needs a minimum of 5 minutes. And if you can get it on there for 10 to 20 minutes, that's even better. But typically we're in such a hurry, we're seeing such high volume of patients, we don't have that kind of time to wait too long. Now, to address the question directly, with the use of traditional negative pressure, you certainly can. And I think if you're doing if you're just washing the wound, you're rinsing the wound, and then you're soaking with Vashe for a period of time in a gauze, somehow it has to be delivered. And then after that soak is completed, then you can switch back to traditional negative pressure. I think that makes sense. If you're trying to squirt negative pressure onto the surface and then immediately apply the foam dressing, I don't think that's going to be very effective, because once you apply the negative pressure, you turn it on, all that, the Vashe will be just sucked back out. And there's going to be very little left on the foam. So I think that's counterproductive to do it that way.
Yeah, so I think the soak time is really important. And if you cannot do it via installation, for example, in the community, uh, if you have NPWT but no installation, soak it well, then apply the NPWT. If you don't even have standard NPWT, then I think Dr. Kim recommended just soak it. It's a perfectly good, slightly slower way to achieve your effect, and that's what we are advising. Now, here are some practice questions. Um, what rate are you doing the installation of Vashe? This is for you, Dr. Kim.
Yeah, I
What rate?
just, we played around with different settings for a long time. And, on the Solventum device, as you all know, there's the default setting. And that seems to be the right amount of cycling, if you will. Now, in those cases where I feel like I want more rapid cycling, you can certainly decrease the negative pressure time and even decrease the amount of dwell time. But again, if you're using Vashe, I would not decrease it less than 5 minutes, because I think you're not going to get the effect that you're looking for. But we know that if you do it that way, you're going to have to hang more bottles of Vashe, and you're going to have to change out your egress canister more often. And so this goes to one of the questions that I was reading on the chat of, like, how often are you supposed to do dressing changes with installation therapy with Vashe, for example? And some people say, well, they heard that it's now you can increase the length of time between the two dressing changes. And somebody on the chat said, well, I'd like to do it 3 times a week. You can do it as many times as you want during the week. I just think from a financial and workload perspective, the less frequently, the better it is for you all and for the patient if it's painful. And you can get away with that because it's not like traditional negative pressure, because if you waited too long with traditional negative pressure, what happens? The tissue invaginates in the foam and it's very painful and it can bleed. Remember, every time you're instilling solution, you're creating a separation, a lubrication, if you will. So that foam is less likely to be attached to the tissue. So you can get away with longer duration between the dressing changes. However, we also know that with greater healing potential using instillation therapy, that the wound size will start to shrink. And so if you do that, then you may have to change the settings. And if you wait too long, you're going to get leaks. Because your wound volume has gone so small, you don't need the amount of solution that you initially started with. So you're going to have to kind of play with that. Now, some people advocate for more rapid cycling if it has heavier bacterial burden, it's heavier bioburden. And I mentioned that earlier, and some people say that it works very well to do that. I have not seen any big difference, honestly, changing the cycling, because I played with that a lot, the timing of things and everything. I don't think it really matters.
Would it be beneficial to use silver foam every time as opposed to using black granny foam with regular NPWT? Is
So
the
that
question clear, Dr. Kim?
Yeah, it is very clear, because I get the silver question all the time. I am not a proponent of silver. I think the 10 times cost increase using that silver dressings versus non-silver dressings is not justified based on the data that's available today. Meaning, the best data out there was published by Marissa Carter, who did a meta-analysis, showed silver had no beneficial effect on wounds as far as reducing bacteria. There's a lot of in vitro studies, lab studies, and perhaps some animal models that show silver can reduce bacterial burdens, but those doses, the concentrations of silver in those cases, are extremely high. And so I don't think it's of benefit to use any kind of silver impregnated product, especially when you're using instillation therapy with Vashe, because you're hitting it with a 1-2 punch. I don't think you need anything more. One of the things that I would recommend is, if you use the Solventum foam, they have what's called the Cleanse Choice foam, which is the waffle foam or the egg crate foam. You guys have probably seen it. That does not come in silver. It's just a traditional foam with big punched out holes that is able to debride, I think, really well in combination with things like Vashe. So I'm just not a big fan of silver in general. That's my bias. I may be completely wrong. I just don't think the data is that strong in it.
Thank you so much. Now, I have a really detailed question here, and I love the detail in the question. When you talk about faster cycle to avoid the block alarm, any specification every 1 hour instead of every 2 hours? Also, I have tried the double track pad. It worked great, but it's very expensive and not so easily accessible. I Can you address those questions?
Yeah, as far as the expense part, it probably is a little more expensive, because it is more material, if you will, that you're disposing of. But ultimately, our decisions are made for clinical outcomes, and if you need a clinical outcome that instillation can provide without having to deal with the alarms, which, quite honestly, at our last consensus panel, we had a lengthy discussion on this specific topic, and not everybody gets those. And it doesn't even matter anatomical location. Some people get it, some people don't. I have not had that alarm consistently, even in wounds that you would think that you would get some sort of alarming. Although, again, the caveat is I surgically debride very aggressively. And so maybe there's just not enough tissue to clog up the ports. But I think uh, some people will say, well, I didn't get that with normal saline. Well, some people did get it with normal saline too. So it's not the precipitation of the Vashe that's causing that. I think it's just the aggressive action, the mode of action of those two things working synergistically.
So this question, um, two questions for you. Apologies. What consensus panel are you referring to, Dr. Kim? I think the attendee is asking about the panel we did at SAWC with plastic surgeons and Lutio and others, and the paper. Dr. Kim, can you refer to that paper? Just you don't have to pull it up, but tell people how it came about and
Yeah, it
how it
was
was
just
international.
Yeah, like I think I mentioned in my lecture, we've had a series of these international consensus panels that convened. And so I asked that you read the paper, and maybe Beno can send a link to that paper where we talk specifically about agreement on certain techniques that are used, what solutions should be used, and all of that. So, please feel free to read that. And if you have any further questions, I'm sure that Beno can answer that, or he can forward those questions to me and I can answer it.
And maybe what we'll do
Yeah, as far
too,
as
just on that
I'm
note,
aware,
is we'll be sending out just to jump in really quick, we'll be sending out certificates of attendance to everyone here. So in that email that you get, we'll do our best to see if we can grab the DOIs for maybe the articles from here, just to make it easier for you to access. I know that was one of the questions that came up for those that were referenced in here, but you'll also have an ability to respond back to that email, and we'll get you in contact with Benoit and Ergo.
yeah. Um, so I believe this is the last consensus panel that happened on installation, Dr. Kim,
So
in the
far.
world,
Yeah.
and I'm sure new ones will come up, and we are going to take part in that. Now, this is a perennial, Dr. Kim. This is with regard to NPWT leading to bacterial increase in the wound bed.
Mhm.
This is also not a surgically clean wound. Are you concerned about NPWT being applied with germs proliferating? And does that chance decrease with installation, in particular with Vash? I built on that question a bit,
Yeah.
so I
No,
apologize.
no,
Go ahead.
it's a great question, and yes. So the vac smell, you guys all know what that is in the audience, and we've been told it's the deterioration of the polyurethane. That's just simply not true. It smells like bacteria. We all know what bacteria smells like, and there's data that I showed you in this lecture that showed there was an increase in bacterial proliferation with traditional negative pressure. Now, having said that, uh, that paper and what I'm referring to is first of all, it's not in humans, so we don't know exactly what happens in humans. It's in a controlled environment, so we're not sure. But I think that the benefits of negative pressure are able to overcome the colonization of bacteria, not necessarily infection, because we know we see infection with standard negative pressure sometimes. But I think that we see infection that happens with negative pressure. We see lots of colonization that happens with negative pressure. And so this is why I prefer using installation therapy, because we also know in both animal, human lab tests that using installation therapy with an antiseptic will significantly decrease the amount of bacteria in the wound surface.
Fantastic. I have one more question here, and this one is a little bit mystical or mysterious. Second part to my question: would you have the patient apply some compression to the wound to help close?
Well, it depends on the type of wound. If compression is one of the etiology, the edema control is very important. Yeah, of course, you want to do compression. Now, can you do compression with negative pressure? Yes, you can. You just got to make sure that the tubing is not pushed against the skin. You have to protect that skin. Can you use installation therapy with compression? Well, again, we use it on the acute side. So yes, we try to do some minimal compression at bedside in the hospital, but usually it's for infection that we're dealing with. So for me, clearing the infection takes priority, and the edema control is secondary at that point. Now, once I clear the bacteria, then compression then becomes even more important.
Um, would you use installation and PWT on unstageable pressure injuries? Would you be cautious due to not knowing where the wound bed is?
Yeah, I mean that's a great question. One of the things that you need to think about is, again, you need to do a full examination of the wound. You got to find out where the nooks and crannies are, because you need to fully explore it. Is there bone exposed, which is okay with installation therapy? That's fine. If tendon fascia, that's okay. It's for using installation therapy. But you just for the betterment of the patient and your awareness of the characteristics of the wound, I think you need to do some full exploration, because I think you get into trouble if you don't. And I'm going to give you an example. We've had some issues within the last year of retained foam, and we've done some things to prevent that from happening, but really it's about examining at every wound dressing change to make sure that you don't have any foreign bodies in there, that the wound is actually improving, because if it's not, maybe negative pressure is not the answer for that patient. So you have to do a full exploration and a full physical exam of the wound before you make any clinical decisions.
Great. I have a question that I'm going to generally ask of the great attendees over here. I believe there are hundreds here, um, and then more questions relevant to the topic. This is, I would love to ask, just like you all told us where you're from, is this a suitable topic for presentation at a live meeting, such as the NSOC meeting, I believe, coming up in Montreal, or any other national meeting in Canada, whether Dr. Kim can do it remotely or in person, if he can find the time to fly? Would that be a good topic for discussion? um, exactly the same topic, but with more, with a different audience, and maybe some of you live present. So please
And
keep the responses.
what I've done here is I've just put a poll up here for those in the audience who are interested to say, you know what, is this something that you do want to potentially, as an audience member as well, have that more interaction and discussion in person? The poll is up there. Of course, we understand that remote is also beneficial too. So I'll leave that up. Well, maybe expand on that, and if maybe you can talk a little bit to the value of having some of these conversations in person with everyone, and even the workshop side of things, or the hands-on, getting people to talk to people, show some techniques, show some skills.
I'll tell you,
Okay.
I love traveling through Canada. I've been to every province in Canada. It's an absolutely beautiful country. I'm happy to be up there.
Well, how many? There are about 10 provinces in Canada, or
Uh,
maybe seven. I'm not
I,
sure of the number. My geography is not good, but
regardless of
we'll
that,
have
it's
you.
all beautiful.
Yes, no, Canada is
Um,
beautiful, no
but
doubt about it.
one of the things I do want to address a question that was sent by Vanessa regarding interface stressing. And this is a question I got a lot as well. One of the things about interface stressing, overexposed tendon, fascia, capsule, people are like, oh, you got to put something over the top of that before you apply negative pressure. That may have been true with traditional negative pressure because you don't want the soft tissue to attach to the foam. It's painful dressing changes. Perhaps you're going to cause bleeding and disruption. But again, if you're using instillation therapy, it's hydrating the wound surface and it's actually preventing the attachment of tissue. So if you're using instillation therapy, you don't have to worry about that, because here's my worry of interface dressings in general. Let's say you use Zeroform, which is petrolatum based, right? You guys know it's oil based. It's a slimy kind of Vaseline based. So if you're using that as an interface dressing and you're applying traditional negative pressure over the top of it, the benefits of negative pressure foam on top of the surface is then negated because of that petrolatum that has been, it's immersed, that dressing's immersed, so it can't penetrate to the wound surface. Now, if you use instillation therapy, like I said, you don't need to use interface dressing. And using interface dressings, again, will decrease the pressure differential between the surface of the wound and the foam dressing. So I never use the interface dressing. Now, some people will say, how about over grafts, like say for vascular surgeons over groin incisions? I think it may be some indication for that in that location, because there's a major artery that they just had to, move some muscle, or there's some graft exposed. And if you accidentally attach something to it, you can rip it all apart. Perhaps that's probably the only case. In the lower extremity, there are no major vessels that I'm worried about that it will disrupt if I use it directly on the surface of the wound. Other parts of the body may be very different, but like it says, like groin incisions, dehisced groin incisions, that's one example. Probably around the neck and the head is probably another example. But really, there are very few where you're really worried that it will somehow disrupt the underlying tissue or the construct that was placed there.
Yeah, I have a comment here that I want to repeat. We have been using Vash with NPWT for about a year in community, uh, and then it's in Ontario. So in community, I guess you can get installation in some places. We have noticed that wounds have been healing quicker and caused less discomfort when using NPWT. I love the product. Now, less discomfort, I guess, it's competitive and it's difficult to, because it's not a randomized controlled study observation. Pain effects with VASH, have you noticed any, Dr.
Not
Kim?
not with Vashe or with instillation therapy. I will tell you, you're right. There's been no visual analog scale kind of pain studies using instillation therapy, but I will tell you anecdotally, after having applied thousands, is that the patients, they have less pain. I think one of the reasons why is you're washing away the inflammatory factors as they're produced at the local wound site. So that's one. Number two is for dressing changes, it's easier and less painful because it's not attaching to the underlying tissue. And number three, I think there's a temperature differential between the solution. Say if you're using Vashe hung at room temperature, and then the body temperature is 20 to 30 degrees higher because it's an open wound, it's inflamed typically. So it's dropping or cooling that wound surface. So I think that cooling effect also has to do with the decrease in pain.
That's fantastic. Now, how many? I guess you have used it on at least dozens of patients, if not hundreds. Have you yourself had any blockage issues when you have used
No,
it?
and like we said, we discussed this a little earlier. No, Debashish, again, I'm not saying it doesn't happen. It probably does happen. Maybe my fellows or somebody is troubleshooting it and I don't know about it. But even during its early, my early experience when it first came out, we really put it through its paces, and we really never had that problem. So this is why it's perplexing to me, and other people have, by the way. And people even like Marianne Obst, who's the world expert, has had this problem. But I don't think it was somehow attached to Vashe, and I don't think that's true. Vashe really is not the major driver in that. I think you're just getting a greater, like I said, removal of the bacterial bioburden and the bioburden in general. So I think that's what is causing it, because I think it's debris. And if you look into your phone where it clogs, where you're saying it's precipitated, I want you to look at it. Are they crystals? Or are they soft tissue debris? I want you to take a look at that the next time that happens. Because I've not seen, people have sent me pictures of lily pads with what they say crystallization, and you kind of zoom in that, I'm like, that's all dead tissue. I don't see any crystals. So it can't be a chemical reaction with Vashe. So again, I think it happens. I just don't see it very often or ever. But just be aware that it's not the Vashe connection is not a real connection.
Well, thank you
Listen,
for touching on that. And one of the things I just wanted to reiterate in the chat here, because I think I'm echoing everyone in the chat when we're saying excellent session. Thank you so much for the information, the clarifications made, and really for taking so much time here to go through all these questions here. It's always refreshing and rewarding when we have a good opportunity to go in depth a little bit more about this. So on that note, I just want to thank both of you, Dr. Chakravarty and Dr. Kim, both. I think it's been so beneficial having you both online here. I'll just remind everybody that this is being recorded too, and I know there might be some other questions that could be coming up here. So if you do have further questions, as we said, we're going to be sending out a certificate of attendance. Ergo will be getting in touch with you if you do have any further questions about Vashe too. Please do email those to us, but we'll make it really easy for us, for you to get in touch with us. And I know we've got our national conference coming up in May soon, and Ergo will of course be there with you too. So we also encourage you to come to Montreal, come to our conference, and definitely ask some questions in person. And you'll definitely see some great colleagues there. We'll definitely go into this in more detail with you. So with that, we'll conclude for today. But thank you both so much, and we hope you both have a great rest of the evening.
Thank you, guys.
thank you so much.